Welcome to join the PCR e-course, the renal denervation, putting guidelines into practice. And in this session, there are two parts. The first part is from me. I will share with you what is the patient identification tool. I'm Dr. Tzung-Dau Wang, the interventional cardiologist and the professor of medicine from the National Taiwan University Hospital. And I'm also the president of the Taiwan Hypertension Society. I have nothing to disclose. And first, I would like to share with you what is the purpose for the patient identification tool. I think the purpose is twofold. The first is to identify the candidates for renal denervation, and the second to construct a reasonable pre-renal denervation flowchart for patient assessment. And what I said is based on the three consensus published till now. The first is the Taiwan consensus, which I was the chairperson and published last year. And the second is the Asian RDN Consortium consensus, what I am also one of the member. And finally is the Italian consensus, and the Professor Ribichini will detail that in more detail in his session. And when we consider who will be the candidate, we have to consider that in three aspects. The first is from the blood pressure's perspective, what kind of blood pressure profile is more suitable for renal denervation. And the second is from the patient's perspective, the patient characteristics, what is the high risk patients? Because the high risk patient will get more benefits from blood pressure lowering, that being demonstrated repeatedly in pharmacological trials and also probably renal denervation. And finally, what features are related to sympathetic overactivity, especially in patients with hypertension. So I will separate that into three sectors. The first is about the blood pressure, but yeah, according the renal denervation will produce year-long blood pressure reduction, one-time procedure, year-long blood pressure reduction, maybe lifelong. And so nighttime blood pressure and early morning blood pressure is hypertension in nighttime or early morning is very suitable for renal denervation because it can provide all day long blood pressure reduction. So mass uncontrolled hypertension are suitable blood pressure profile for renal denervation. And another aspect from the blood pressure point of view is that renal denervation should not be viewed as a last resort for blood pressure control. It should not be reserved for those patients with resistant hypertension alone. Actually, based on the spiral hypertension off-med and radiant solo study, patients with treatment naive blood pressure hypertensive or uncontrolled with only 1 to 3 drugs in the hypertension on-med trial, or the traditional resistant hypertension in the Simplicity Hypertension Japan trial, all demonstrate renal denervation consistently effective in achieving a significant blood pressure reduction in all spectrum of hypertensive patient. So these are two blood pressure profile aspects. And in summarize, we summarize all the recent renal denervation trials, the inclusion criteria about blood pressure into this slide. And what I would like to mention is the importance of ambulatory blood pressure recording. Based on that, we can identify patients with mass hypertension or mass uncontrolled hypertension. Both of them are ideal candidates. And the second aspect for candidates is about the patient. From the patient's perspective, we create an acronym called RDNI2. These 5 characters identify the 5 key features of candidates who will be more responsive or get more benefits from renal denervation. The R means resistant. Even though I said resistant hypertension should not be considered as the only candidate for renal denervation, but patients with resistant hypertension had higher baseline blood pressure. And those patients with higher baseline blood pressure will get more benefit or will be more responsive. That being observed in pharmacological trials and also in renal denervation. So resistant hypertension is still a candidate for renal denervation. And the D means damage, hypertension-mediated organ damage. That means long-lasting hypertension or already atherosclerotic cardiovascular disease. That's all side effects or complications of hypertension. So those patients are at higher risk and will get more benefits, clinical benefits from blood pressure reductions through any measures. And then the N and D means non-adherent or intolerant. The patient either will feel some side effects of the drug or by themselves, they don't like the antihypertensive drug. Even though they get only mild to moderate hypertension, we should let them realize there is a treatment strategy called renal denervation that could be provide than effective and sustained blood pressure reduction. And finally, the two. Two means secondary hypertension. Secondary hypertension being routinely excluded in trials and also being routinely assessed in patients with poor control or uncontrolled hypertension. But secondary hypertension alone, after treatment, if the patient still got hypertensive, we define those patients as treatment-resistant secondary hypertensive patient. Those patients we should not exclude from the treatment of renal denervation because the cause of hypertension are multiple, and renal denervation is effective for all kinds of hypertensive patients. So if that's belonging to the category of treatment-resistant secondary hypertension, consider renal denervation. They are still candidate for renal denervation. And finally, what features are associated with higher sympathetic tone? The first, high baseline heart rate, greater than 74 every 24 hours. And the clinical features like obesity, obstructive sleep apnea, paroxysmal atrial fibrillation, clonidine sensitive, aldosterone antagonist resistant. Those are features related with sympathetic overactivity and should be responsive to renal denervation. And the last point is isolated systolic hypertension should not be excluded or viewed as a contraindication for renal denervation. That being demonstrated in a recently published the GSR data in JACC 2020 by Mayfield. So after this candidate issue, and then we move to the second purpose for the identification tool, the pre-renal denervation assessment, we created another acronym called RAS. That means renal artery angiography, ambulatory blood pressure assessment, secondary hypertension causes identification. We first have to all the way back from secondary hypertension exclusion or identify them, treat them, but if the blood pressure still remain uncontrolled, we confirm the blood pressure status by ambulatory to look at whether there is a daytime or nighttime or mass uncontrolled hypertension. And finally, we check the CT renal angiography. That's very important because the key to the success for renal denervation is comprehensive ablation. And maybe around 20 to 30% of patients got either accessory or some multiple renal artery that could only be identified by the CT angiography or very detailed analysis of aortogram. So, and then we listed some post-renal denervation assessment, including a CT, follow-up CT, and the ambulatory blood pressure. So in conclusion, in my part, I introduced you the patient identification tool that could be separated into the RDNI2 and RAS. RDNI2 is for the 5 key features of candidates, and the RAS means the pre-RDN assessment, 3 key components. Blood pressure profile, the mass hypertension is the blood pressure profile. 24 hours is very important. And finally, we emphasize the importance of comprehensive ablation, including both main, branch, and accessory renal artery. I hope you enjoy it. Thank you.
Hello, ladies and gentlemen. I am Flavio Ribichini. I am an interventional cardiologist and the director of the Division of Cardiovascular Medicine at the University Hospital in Verona, Italy. I don't have conflicts of interest with this topic, which will be focused on the analysis of a recently published position paper proposed by the Italian Association of Hypertension. The paper addresses many important items on the management of hypertension, but specifically when to perform renal denervation in patients with resistant hypertension or the difficult to treat hypertension. The definition of the difficult to treat patient with hypertension comes after the evaluation of a multidisciplinary team that takes into account, first of all, the ruling out of secondary hypertension, the analysis of the prescription of a rational drug scheme, the evaluation of drug tolerability and adherence, comorbidities, global cardiovascular risk assessment, and of course, patient's preference. Let me share with you a personal point of view of what an hypertensive patient might be. One patient is just having hypertension. It's normally a younger one. He might be a true resistant hypertensive patient or just one being under suboptimal medical therapy or having secondary causes or simply not taking the pills. A different patient is that with hypertension on top of other more important problems that normally are older and have been hospitalized, being that for chronic kidney disease, coronary artery disease, heart failure, arrhythmias, or peripheral artery disease. So the possible candidates that can be treated with renal denervation can be those with uncontrolled office and ambulatory blood pressure, those under treatment with an association of renin-angiotensin blocker, calcium channel blockers, and diuretic, but not reaching the target, and of course, after the exclusion of secondary causes and being eligible for the technique. Scientific evidence might include in this population those not with adverse effects of spironolactone, with poor drug adherence despite extensive counseling. And of course, again, as I said before, those preferring the interventional therapy. The Global Simplicity Registry is a very large international study that has been treating patients with resistant hypertension with an average of more than 4 antihypertensive drugs. And the study has shown dramatic reduction on both office and ambulatory blood pressure measurements at a follow-up of 3 years. Another difficult to treat population is that of patients with grade 1 or 2 hypertension with uncontrolled systolic blood pressure despite taking 1 to 3 drugs. And additional evidence can include those with intolerance or adverse effects of the drugs, with poor adherence, and very interesting, those having atrial fibrillation or paroxystic supraventricular arrhythmias, or those having a baseline heart rate above 74 beats per minute, in which probably an adrenergic drive is more important than in other populations. Patient preference is again considered an important reason to use the technique. The spiral hypertension on medical pilot study have shown a significant and sustained blood pressure reduction in hypertensive patients being treated with 1 to 3 antihypertensive drugs. As you can see in the slide, both the 24 hours assessment and the office blood pressure assessment has been significantly reduced compared to baseline in all these patients. As a conclusion, the Italian document proposed a multidisciplinary evaluation of these difficult to treat patients in renal denervation center, which has both the expertise of the technique and the expertise on the management of these patients after a global cardiovascular risk assessment, the screening for secondary hypertension, an accurate measurement of the blood pressure, the control of the drug adherence and tolerability, to gather a shared decision making. For those reaching a good blood pressure control and adequate follow-up on time, are for those not reaching the target for a good blood pressure control, undergoing the procedure, the interventional procedure, following the multidisciplinary advice of the team. This is an interesting slide derived from a questionnaire-based cross-sectional survey performed in a German population, showing that among patients with hypertension, but still not taking pills, nearly 40% of them would prefer to undergo renal denervation rather than starting a drug. For those already under one medicine, they still, in a third of patients, would prefer to drop the pills and undergo the interventional procedure. This is the last slide. It's clear that renal denervation has been reported to be safe and effective, both in hypertensive patients and those with more complex global clinical situation that like patients with hypertension, spanning from the high blood pressure to those with other comorbidities like chronic kidney disease, or those being non-adherent to the therapy. It's important always to rule out secondary causes of hypertension. Intensive discussion should be conducted in terms of risk benefits of the therapy, and several evidence-based published guidelines and consensus documents have recommended a range of potential candidates for renal denervation procedure, including those with uncontrolled hypertension, those at risk, and those expressing a strong preference as a part of a shared decision-making relationship. I hope this has been useful, And I thank you for your attention.